This video is on breast cancer. Cancer is abnormal proliferation of cells. So using this very basic definition, we will explore the pathogenesis. So you have normal duct epithelium that mutates, and this is linked to risk factors such as age, estrogen, and radiation, but we will go more into this later. But when this duct epithelium mutates, you get a neoplastic cell, and this leads to atypical ductal hyperplasia. So there's increased division of the cells, so hyperplasia, and it's an abnormal or atypical. Because at this stage it is confined to a specific area, it's ductal carcinoma in situ. However, you can still pick up microcalcifications on screening, but it won't be large enough to be felt as a lump just yet, which is why screening is so important in picking up these cancers early before they can really progress. But if the cell continues to divide, it leads to a greater chance of accumulating mutations, and eventually it can penetrate through the basement membrane, so it is no longer confined to a specific area, and this is known as an invasive carcinoma. This desmoplasia, or laying down of fibrous connective tissue or collagen, manifests as the lump being felt by a patient. So presentation, as we talked about, the lump, it's often painless. If it's painful, you may think of other causes such as mastitis. It is most commonly in the outer quadrant or central areas of the breast, but it doesn't have to be. If the lump and carcinoma divides around the nipple, and the desmoplastic response laying down the connective tissue around the nipple can cause the nipple to be pulled back or retracted, as shown in this schematic. And if that's the case, you get Paget's disease of the nipple. If you also get a rash, which can be orange or erythematous, this is known as poda orange. Again, it's around the nipple. The patient may also have constitutional symptoms such as anorexia, weight loss, or cachexia, as well as symptoms of metastases. It can also spread to lymph nodes, and you can get lymphedema. But where do you get this lymphedema? Well, that's why it's important to understand the lymphatic drainage of the breast. Most of it is done via the axillary nodes. So the lateral axillary nodes, central, apical, anterior, and posterior. So these are all lymph nodes around the armpit, for the subscapularis area, around the pectoralis, as well as the top of the armpit. And most of those end up at the apical lymph node anyway. Those that don't go through the axillary nodes mostly go through the internal mammary nodes, which is along the parasternal area. So going back to risk factors, so remember the factors that predispose a cell to mutating abnormally, which sets off that chain of events. It could be age, so over 50, family history, because the patient may then have a BRCA gene, and these tend to be more aggressive and can present at a younger age, so sometimes even in the 40s or early 50s. Prolonged estrogen exposure, because estrogen can cause the cell to mutate, and this could be in the case of early menarche or late menopause, or if the patient is on hormone replacement therapy, where they're essentially getting exogenous estrogen. Obesity and type 2 diabetes are also a factor, because it affects the way estrogen is metabolized, as well as ionizing radiation to the chest for whatever reason. Diagnosis is classically done via triple assessment. So the first component is clinical assessment, where we consider the presentation of the patient, the signs and symptoms, as well as the risk factors. Imaging is then done, so mammograms if the patient is less than 35, and ultrasound if the patient is greater than 35, because the younger breast may have increased calcium deposits, and you don't want to get it confused with the microcalcifications of the tumor, which you're trying to pick up. The final component is a core biopsy, where you look at the architecture. You want to see if it's penetrated through the basement membrane, because this would be consistent with an invasive carcinoma, as well as cytology, looking for neoplastic features such as a lot of mitotic figures or high nucleus to cytoplasm ratio. Treatment, as with most cancers, includes chemotherapy such as antimicrotubule drugs. However, this can lead to peripheral neuropathy and cardiotoxicity. Radiotherapy, monoclonal antibodies, and anti-estrogen therapy such as tamoxifen are also options. Thank you for watching. I hope you learned something. If you did, please tell a friend who may also find it useful.